January 30th, 2025, and it is 12:38 for the record. And today we have the reinsurance overview. We have the Deputy Commissioner from Minnesota Department of Commerce, Julia Dreyer. Julia, are you here? Would you like to come forward? And whenever you're ready, please proceed.
Sounds good. Good afternoon. Thank you for having me here today. My name is Julia Dreyer. I'm the Deputy Commissioner of Insurance at the Department of Commerce. I really appreciate the opportunity to share with you today some information about our state's reinsurance program, otherwise known as the Minnesota Premium Security Plan. Reinsurance essentially provides insurance for insurance companies to help cover the cost of caring for the most expensive patients. Reinsurance is a proven program that stabilizes market premiums, maintains enrollment levels, and helps to ensure that consumers have meaningful choices in the individual health insurance market. Without action this year, the premium security plan will be depleted, and Minnesotans on the individual market are at significant risk of a 25% premium increase in the individual market. So this means that people will likely lose insurance, fewer Minnesotans will receive primary care, and more people will rely on expensive treatment in an emergency room. Just want to make sure my slides are actually moving because I can't see what you see. Beautiful. Love it when technology works. All right. So as background, roughly 187,000 Minnesotans get healthcare coverage through the individual market. Enrollees include people who don't have access to insurance through their employer or a program like Minnesota Care, Medicare, or medical assistance. They consist of independent contractors, farmers, employees working for a small business not offering health insurance, as well as early retirees. As background, in 2016, Minnesota's individual insurance market was in crisis. There was a federal reinsurance program that had expired. Commerce was seeing double-digit rate increases and requests from plans to cap the number of enrollees, along with one company exiting the market. Additionally, we are seeing shifts in plan designs like creating narrower provider networks to help carriers reduce costs. Gross average premiums saw a 155% increase from 2014 to 2017. These premium increases contributed to fewer people buying insurance, and we saw enrollment drop almost in half from its peak in 2016. So all of this was pointing to a market collapse. So to address this issue, Minnesota established a reinsurance program in 2017 to help stabilize the individual market and lower premium costs for those who have to buy insurance on their own. We were the second state in the country to establish a reinsurance program. Alaska, unfortunately, bested us by a few months on that one. Our program reimburses 80% of those claims that are between $50,000 and $250,000, and in 2022, the coinsurance rate was reduced to 60%. These claims are generally for individuals who have complex health needs, so think someone who has cancer, diabetes, in addition to one or more other chronic health conditions, or a premature baby who has an intensive care stay. Reinsurance payments must be used to pay claims and cannot be used for administrative expenses for the plans. So we operate this program through a federal program called a 1332 waiver. Section 1332 of the Affordable Care Act allows states with federal approval to waive certain requirements of the law as long as we meet certain requirements. Specifically, we have to prove that our program offers coverage that is at least as comprehensive and as affordable as it would be without the waiver. It also has to cover a comparable number of people. And finally, it can't increase the federal deficit. Through this program, the state receives federal funds through savings generated through lower premiums. This is based on the amount of premium tax credits that the federal government would have otherwise provided to eligible individuals absent the waiver. And so to date, we've received over $650 million in federal funds. The state's reinsurance program has been successful in three key ways. One, we've been able to maximize federal funding to help keep premiums low for everyone in the individual market, including those who buy insurance somewhere other than MNsure. Two, we have stabilized the individual market, so we've had carriers stay in our market. We did lose one small carrier to a merger, but also gained a new carrier as well. Every county in Minnesota has at least 2 different carriers offering coverage, with most having 3 or 4, and every county has multiple plan options for people to choose from. Finally, we have reduced premiums by generally 20%. It dropped to 15% when that coinsurance rate dropped to 60%. Commerce doesn't do this work alone. We're very lucky here in Minnesota to benefit from the expertise and structure of previous healthcare efforts and have the Minnesota Comprehensive Health Association, or MCHA, to oversee the day-to-day work of the reinsurance program. So prior to the Affordable Care Act, MCHA managed the state's high-risk pool to help provide coverage to individuals with pre-existing conditions or other high-cost needs. And as a state, we've been able to rely on MCHA's governance, leadership, and payment infrastructure to help manage the program. This work is overseen by a board that consists of members from across the healthcare sector, as well as community members. Had a few more points. MCHA also works with Wakely, which is an actuarial company, to evaluate and report on high-cost claims throughout the year. And we also have required quarterly and annual reporting for the program, in addition to regular state and federal audits. As I noted previously, Minnesota was the second state in the country to establish a reinsurance program, and since then, many other states have built on our experience here in Minnesota and established their own. These programs all look slightly different depending on the state's particular needs, and in general, there's a lot of flexibility in terms of how a program's structured and how it's funded. For example, some programs only reimburse for claims associated with certain medical conditions. States also have different coinsurance rates and caps, and may in some cases pair their reinsurance program with other health reform efforts. Minnesota is one of 5 states that rely on general funds to pay for the state share of the program. Other states leverage a combination of taxes, fees, and assessments or other sources of income to pay for the state share. This includes things like interest income, exchange user fees, and personal responsibility fines. Of the states that have assessments, most are paid by insurers, although states do vary in terms of which insurers are included. This list includes Alaska, Colorado, Delaware, New Hampshire, and our neighbor, North Dakota. Other states have relied on premium assessments, and that includes Alaska, Colorado, Idaho, Maine, Maryland, Montana, and Oregon. Colorado did have an assessment on hospitals, but that's been since phased out. So our current reinsurance program is funded through the end of 2025, although we have authority from the federal government to run our waiver through the end of 2027. Assuming this funding expires, people, as I noted, will be facing a 25% premium increase on top of normal cost increases. Additionally, in 2026, people in the individual market who currently have access to increased tax credits, people in the individual market currently have access to increased tax credits that limit their premiums to 8.5% of their income, and those tax credits are also set to expire at the end of 2025. So we're worried about a couple things happening in the individual market as a result. One, we know that when premiums increase, people either drop coverage or may enroll in a plan with a less expensive premium but with a higher deductible or higher cost sharing, making it difficult for people to pay for needed care. Two, we're also worried that a drop in enrollment will make it difficult for Minnesota to contemplate other strategies to address the issues in our market. So access to federal pass-through funding is retrospective, and it's based on an actual amount of federal tax credits that people are accessing. So in other words, if fewer people are enrolled in the individual market, it means we might lose out on federal funds here in Minnesota. And then 3, we also run the risk of returning to a 2016 situation where carriers stop participating in some or all of the market and limiting people's choice of insurance carriers. So just wanted to note, here are our projected costs for the program. A couple items, because these estimates do look slightly different from the estimates we provided last year for a couple key reasons. One, the enrollment in the individual market has increased substantially. So we had over 180,000 Minnesotans in 2024, and we're expecting that number to increase as well, given MNsure's record-breaking enrollment this year. We also previously included the enhanced federal subsidies in our estimates, which increased the amount of federal pass-through funding we were receiving, and we've since taken that out. We know reinsurance works, but obviously funding it has been a challenge. Following the lead of other states, we are proposing instituting an assessment to help ensure that there's a stable funding source for Minnesota's reinsurance program. We are assuming that MCHA would administer roughly a 2 to 3% fee on insurance companies, which includes large and small group health insurance plans. This assessment would go back to the health insurance marketplace and fund the state share of the reinsurance program. The hope is that by creating an assessment, That will be an administrative update to our waiver and will not require us to fully resubmit our waiver application. But again, there are some obvious questions given some of the changes in leadership at the federal government. The proposal also assumes that funding for the basic health plan or Minnesota Care is held harmless. The proposal reduces the size of the reinsurance program if federal funding for the basic health plan is negatively impacted. And with that, I am more than happy to take questions.
Chairs, questions, members? Senator Rasmussen.
Thank you, Mr. Chair, and appreciate the Assistant Commissioner coming in and talking about the governor's proposal and giving an overview on reinsurance. Mr. Chair, my question for the Assistant Commissioner is, so for this tax increase that the governor is proposing, how much revenue does that new tax, or I think what the governor is calling a surcharge, raise?
So it's set to raise the amount of the state share, so 236 for plan year 2026 and 276 for plan year 2027.
Got it. Thank you, Mr. Chair.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Assistant Commissioner. And so, we're talking about correct me if I'm wrong, it's about a $500 million amount of money over the course of a biennium. That would be new revenue coming into the state. And I guess, the whole point of reinsurance is to try to make health insurance more affordable for Minnesotans so that they can get the care that they need. And it's, I think, as you stated, Assistant Commissioner, I appreciate this, saying, talking about the success of the program and that it's helped to do that. And I guess my concern is if we're going to come in with a $500 million tax increase on Minnesotans' health insurance, that we're really not going to be addressing that core problem that Minnesotans have, which is the high cost of healthcare, the high cost of health insurance, and that we're just kind of moving dollars around within the healthcare ecosystem, but we're actually not bringing down costs. So that's one. I'm glad the governor is interested in continuing with reinsurance. My biggest concern is how the governor is planning on paying for it by effectively taxing healthcare and making it more expensive.
Deputy Commissioner.
Chair Dahms. Yeah, so the question, just want to reiterate what exactly the question was. If you could clarify. There was a lot there.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Assistant Commissioner. I guess I didn't have any question, was just making that as a comment on the governor's proposal. I guess one question that I did want to ask is, could you list out the members that are a part of MCHA? I just wanted to understand who's a part of that association, what organizations are involved in that. You mentioned that in your presentation.
Deputy Commissioner.
Chair Dahms, Senator Rasmussen. So the MCHA membership in current statute consists of, as you see on the slide, self-insurers, fraternals, joint self-insurance plans regulated under Chapter 62H, so that's like MEWAs, the Minnesota Employees Insurance Program, which, as I understand it, doesn't exist, HMOs, and community integrated service networks, which again, there are none here in Minnesota.
Senator Rasmussen.
Thank you, Mr. Chair, and thank you, Assistant Commissioner. I guess it could the department provide us with the list of actual entities that are on that would be assessed the surcharge, just so we can understand who it's impacting?
Deputy Commissioner.
Chair Dahms, Senator Rasmussen, we are looking into that. We did base our estimates based on annual statements, so we're just trying to make sure we're not disclosing information we're not able to disclose at this point.
Senator Rasmussen.
I'm good.
Senator Duckworth.
Thank you, Mr. Chair. I appreciate it. I've got a few questions. Hopefully that's okay. First and foremost, I just want to make sure we're all on the same page. You would say that the stance of the department is that reinsurance is a good program. Is that correct?
Deputy Commissioner.
Chair Dahms, Senator, reinsurance is a program that has worked to reduce premiums in the individual market.
Okay.
Senator Duckworth.
Thank you, Mr. Chair. I apologize. I'm a pretty simple guy. Reinsurance is one of the more complicated things that we deal with over here, so I'm going to ask some questions that kind of try to keep it in layman's terms. So it's true that the reinsurance program keeps the cost of insurance premiums low for a lot of folks here in Minnesota. Is that accurate?
Deputy Commissioner.
Senator Dahms, yes, reinsurance works to keep premiums low for people who buy insurance in the individual market.
Okay. Mr.
Senator
Chair,
Duckworth.
And I'm just trying to, the last 2 years have been a bit of a blur. There's a lot of stuff that passed, moved kind of fast. So I'm trying to remember how we got to the situation that we're in currently. Is the reinsurance fund in danger of being depleted because we simply ran out of money? Or did some money that was supposed to be in there get moved? Could you kind of help establish some context for me, please?
Deputy Commissioner.
Chair Dahms, Senator, yes, the money that was originally appropriated in the program was moved to the general, or swept from the premium security account.
If I may, Mr. Chair.
Senator Duckworth.
Thank you. If memory serves, I think about $300 million that was already in this account before was moved and transferred to the general fund and used to grow government spending, now resulting in this fund being near zero. And if I understand the proposal from the governor, it's to now pass a new tax to replenish the money that the legislature moved out of there over the last 2 years. Do I kind of understand that correctly?
Deputy Commissioner.
Chair Dahms, yes, the governor's proposal is to do an assessment on those carriers in the market to be able, or insurers to be able to fund the program. Again, this is consistent with what other states have done and done successfully.
If I may, Mr. Chair.
Senator Duckworth.
I can appreciate that other states do this, and when I look at those other states and I look at their taxes, they seem to be quite a bit lower than Minnesota. That being said, so ideally, the way the governor is describing this to folks is, hey, we're essentially just going to levy a fee or a new tax on top of insurance providers. Is it fair to say that that will likely result in an increase of the cost of insurance for folks here in Minnesota?
Deputy Commissioner.
Chair Dahms, well, the purpose of it is to be able to reduce the costs for people in the individual market because the tax is currently estimated to go over a wide array of insurers. The premium impact, we believe, will be minimum on individuals.
Mr. Chair, if I may.
Senator Duckworth.
But nonetheless, you would say, common sense says it's likely going to cause insurance to go up a little bit for folks. Is that a fair assessment, or am I completely wrong on that?
Deputy Commissioner.
Chair Dahms, it's not a direct one-for-one.
Okay, Mr. Chair, if I may.
Senator Duckworth.
As far as the new tax or fee, is it capped at all, or is this something that could potentially continue to be raised in the future?
Commissioner, Deputy Commissioner.
Chair Dahms, so as we have it written, the assessment would be to fund for whatever the state share is. So the way the reinsurance program works now, we tap federal pass-through funds first to fund the program, and then whatever else is needed goes to the state share. So what is needed really depends on both, what happens in the market. So if you have really high claims costs or a lot of claims costs in a particular year, that can really increase the state share. The MCHA board has the ability to reduce basically the amount if they feel like that's necessary. And again, that's a decision that the legislature is able to make.
Mr. Chair.
Senator Duckworth.
Thank you, Mr. Chair. So it's fair to say that there's really no limit or cap on this new tax being proposed, that conceivably it could continue to go up or increase if more funds are needed to replenish this fund. Is that accurate?
Deputy Commissioner.
Chair Dahms, it really just depends on the need of the what's needed in the individual market.
Mr. Chair, if I may.
Senator Duckworth.
Thank you, and I appreciate you answering all my questions. I have a very significant concern. Number one, on how we got here, and number two, the issues that we're likely going to see in the future as a result. I find it interesting, and I think I remember having conversations about this not long ago, about what transferring almost $300 million that was already set aside in this fund would do. And now here we find ourselves looking at a significant tax increase to the tune of $500 million that's not capped, that's likely only going to go up in the future, and it's going to result in fees and taxes that increase insurance premiums for the people of Minnesota. This isn't directed at you by any means, but I find that oftentimes we have a short memory in the legislature, and sometimes we have to be reminded of how we got into the situation that we are, and we also need to be reminded of how it's likely going to play out in the near future. So if this program is so valuable to people, which it is, and we want to keep the cost of insurance as low as possible, I don't think the governor implementing a new tax or fee on people to backfill the money that was robbed out of this account to begin with is good governing. And so I hope we continue to have conversations about how we can actually solve this problem and not lead to bigger ones in the future. Thank you, Mr. Chair.
Senator Frantz.
Well, thank you, Mr. Chair, and thank you, Deputy Commissioner. I have a memory of when reinsurance came about. We were told on the floor of the Senate it was a temporary program that would be stopped for a better plan in the future. That was my freshman year in the Senate, 2017. Here we are. This program costs hundreds of millions of dollars. And Mr. Chair, I like the basic logic that we can reduce premiums by taking the bigger claims and paying a little bit less. That makes sense mathematically. But these are hundreds of millions of dollars, and this is a problem that was not solved by reinsurance. And so, Deputy Commissioner, I understand what the governor's proposing. I'm open to any other plans. We have a lot of different voices, and the fact is the cost of health care is going up. The essential benefits are increasing. The cost to provide it per person is increasing. But we're also providing a quality of health care that wasn't dreamt of 50 years ago. So let's be clear, what Minnesotans get in terms of helicopters to accident scenes, cancer treatment, we're doing things for Minnesotans in healthcare that we hadn't even thought of 50 years ago, but it's going to cost money. And I look forward to the discussion. Appreciate that, Mr. Chair.
Senator Green.
Thank you, Mr. Chair, and I do have a question for the Deputy Commissioner, but just to be clear, we were put in the position of reinsurance because we had driven people to a point where they couldn't afford their insurance when the Affordable Care Act came in, and Minnesota's solution to that was a debacle called Minsure that people couldn't afford. And these people were in a donut hole where they couldn't buy insurance even if they wanted to. As I remember those days, that was probably before 2017 when you came in, when we did come up with a fix that should have been temporary, but so far other things haven't gotten cleared up. But Deputy Commissioner, my question is, on the tax that's going to be imposed on the premiums, now you've said that it's not going to be a locked-in tax, therefore it can go up. So how is it going to be gauged? Is it going to be gauged by a percentage of the premium, and that can fluctuate? And who decides when and where it goes up and how much?
Deputy Commissioner.
Sure, Dahms, Senator. So there are two things we have to figure out as we're doing the assessment. One is to make sure we understand so that carriers, when they're submitting their rates, know what they need to take into account. So there needs to be some sort of projection of what would be covered as part of the assessment. But on the back end, the actual assessment, the actual dollars that are paid out to carriers would depend on what has ever happened in the market and what has actually been spent by or been turned in for claims over the course of the year.
Senator Green.
Thank you, Mr. Chair. It doesn't really answer the question. So, and maybe it does. Are you telling me that that you as Deputy Commissioner or the Governor will decide when the tax goes up? How's it going to be based? There's no locked-in number. You're just going to decide every year how much you're going to be charging. Is that how it's going to work?
Deputy Commissioner.
Senator Dahms, Senator, no, it's still based on the parameters of our current reinsurance program. So it's still assuming, so we based our estimates based on a estimated reduction of, in this case, a 18 to 20% decrease in premiums. So if the program parameters change, we could adjust that as well. But that is not, that's a choice the legislature gets to make.
Senator Green.
Mr. Chair, one more time. So you, as the Deputy Commissioner or the Commissioner, is going to decide based on fiscal notes, which I see are changing here by quite a bit from what we had based, and now they've gone up. So in the few weeks that we've had the fiscal note, and now the new projection that's higher, how often could you change those numbers to make them go up and down? And if you can do it arbitrarily, how is anybody supposed to keep up with that or know? I mean, it's going to be fluctuating constantly. How's it going to work?
Deputy Commissioner.
Senator Dahms, so the cost estimates are based on a combination of factors. So we do projections based on projected healthcare costs over the course of the year. So that's just like general things cost more. Hospitals are paying nurses more. We assume that there's increased costs. We look at changes in So right now, we're looking at changes in enrollment in MNsure, as well as changes in the federal government and the assumptions that the enhanced subsidies are going to be going away. So our actuaries do make some assumptions based on the total cost of running the program, and that is where we based our estimates.
One more question, Mr. Chair.
Senator Green?
I think you've answered my question as to who's going to be in charge of raising or lowering this fee or tax. But you haven't answered my question as to how often it can go up. Can it go up every month? Are you going to adjust it by the month depending on what your assessment is? Are you going to adjust it by the year, 6 months? I mean, where's the guideline on that?
I think I should interject here. With the fiscal note that we have, it appears that the numbers they used were the numbers that I used, not that they took it off of my bill, but in my bill, I used the last fiscal note we had. And this appears to be numbers from the last fiscal note we had. So the new numbers, which I believe the numbers here in your handout, they appear to be right. And the numbers at the governor's office are these same numbers. So we'll get into a little discussion on the fiscal note when I present my bill. So that might give some clarity there.
Okay. Then, Mr. Chair, then the only question I have is how often can you raise the fee?
Deputy Commissioner?
Chair Dahms, Senator Green, again, we make some assumptions and to help carriers at the beginning of the year when carriers are submitting rates so that they know what they need to submit for their rates for the upcoming plan year. The actual assessment is based at the end of once all of the claims have come through. So MSHA every year in conjunction with Wakely, the actuarial firm that they work with, they assess the claims over the course of the year and they're tracking that. So they'll know quickly or relatively quickly if claims are going up or down based on projections. And the final assessment is based on the final claims amount that comes in at the end of the year.
Okay, Mr. Chair, so then the
Senator
answer is
Green?
they can only go up annually.
Senator Dahms,
Deputy Commissioner?
Senator Green, yes.
That would have been very easy to say.
The assessment is based at the end of the year.
Senator Lance?
Thank you, Mr. Chairman. Deputy Commissioner, my memory is that there was an agreement when there was a crisis in the insurance market between both parties to do the reinsurance program when it was first initiated. And it was, like Senator Friends mentioned, it was intended to be a temporary fix. My recollection is that the GOP was in control of the Senate at the time, and when it came back up for reauthorization, there was no proposal to replace it with any kind of a longer-term solution. So it became another temporary fix because there apparently hadn't been a serious attempt by whoever it was that was thought to have been working on one to come up with a longer-term solution. So that's my first memory. My second memory, my understanding was that the money that was removed from the fund was essentially surplus money, that the agreement was there'd be a certain amount of money set aside for reinsurance to meet those projected needs. And it turned out that more money ended up in the fund. And so the agreed upon amount was there to take care of the needs, but the additional money was moved back into the general fund for other purposes. So I'm not sure I could characterize it as robbing the reinsurance program to fund other programs. I'd be happy to be corrected if I'm wrong on that, but that's my understanding. Third, there was a reference to the MNsure debacle. You'd have to explain to me then why we have record numbers of Minnesotans who are signing up for MNsure in the last open enrollment period. They sure seem to find some value in the program and meeting their own insurance needs. So it doesn't sound like a debacle. It sounds like a government program that is working exactly as intended, which is to help the citizens of Minnesota meet what can be incredibly expensive medical expenses. Parenthetically, I've spent about 2.5 hours in the last 2 days dealing with an outrageous medical bill from a New York City hospital for a daughter that went in for a flu test. And somehow she walked out with a $1,000 medical bill to get 2 lab tests done to figure out whether or not she had the flu. So, I mean, these medical bills are incredibly difficult to deal with, but they're also incredibly difficult to project. And so it doesn't surprise me at all that a fiscal note is being adjusted when they're based upon projected insurance claims. What a surprise. Our insurance industry in every segment is having difficulty projecting future claims expenses and adjusting premiums to reflect that. It's not just in healthcare where there's so many moving parts, but look at the property casualty area where companies are getting just decimated financially because of natural disasters, which if you ask me are at least partly man-made, that are far above projections and are forcing companies out of markets completely or dramatic increases in taxes, or in premiums rather. So I don't have any criticism that a fiscal note is adjusting projections now, and there'll be future projections are going to be adjusted as more claims experience comes in. So I'd be glad to be corrected on any of my understandings here, but that's my recollection of the way things are working now. Whether reinsurance is a good long-term solution, probably not, but we still don't have a proposal to replace it, as I see. So I don't think the question right now is whether we're going to reauthorize reinsurance. I think the question is going to be, how are we going to pay for it?
Members, other questions? Deputy Commissioner, I do have a couple of questions for you. Senator Howe.
Thank you, Mr. Chair. And Deputy Commissioner, I guess I got a question on the fiscal note. On page 5, it says that they assume that the premiums or the payment's going to grow by 12% each year for the program, but yet when we talk about the MNsure annual growth rate of premiums is only 5%. Why is there a discrepancy between, we're assuming that this is going to grow 12% where the other premiums are only going to grow 5%?
Deputy Commissioner.
Chair Dahms, Senator, I would want to double check with my actuaries to give you an exact answer as to what went into each of those, but the 12% growth is an estimated projected cost, so like what it might cost in the future, and that 12% is slightly higher than general premium costs in large part because claims costs, these are for sicker individuals, so we assume that there is a higher healthcare cost growth for that particular group of claims.
Senator Howe.
Well, thank you, Mr. Chair. I just, when we start making those types of assumptions, I would think they would be backed up with fact. And that's what we should be working toward is make assumptions facts. And that's where I would like to see those numbers if you can actually get some more detail on that. Thank you.
Senator Klein.
Just one quick question, Assistant Commissioner. We're talking about individual market issues, and that's, as you said, 180,000 people currently, maybe soon to be 190,000 people. And we're struggling with how big the tab is and how difficult it is going to be to solve for that. Can you tell me, yesterday, medical assistance payments were briefly halted at the federal level based on an executive order out of the president. How many people in Minnesota were affected or are affected? How many people are on the medical assistance program?
Deputy Commissioner.
Senator, Chair Dahms, Senator Klein, I would need to defer to my colleagues at DHS to be able to answer that.
Senator Klein. Other questions? Deputy Commissioner, I do have a couple of questions. The first one is on page 11 of your handout here. We're showing the cost for 26, 236, and 27, 276. So about a total of, if we take that total, that would be about $512 million. That's what I see in the governor's forecast too. So I'm assuming these numbers are numbers that your department come up with. Would that be fair?
Chair Dahms, yes, that's correct.
So when we look at the fiscal note, which I believe is taking the kind of the numbers from the previous fiscal note of 413,000, so we're seeing a quite an increase there in this 2-year period, being 99 million. I should have said 413 million, so it'd be about 99 million. Can you tell me what comprises that increase? Is it the number of people? Is it the cost of care? What is it that's driving that up that much?
Yes, thank you, Chair Dahms. So the $413 million is based on the legislative language we received as part of the fiscal note. The higher number that we've used in the governor's budget and that we presented here in the slides, it's larger for two reasons. One, there are more enrollees in the individual market, so our individual market is a lot larger than we were originally anticipated, which is a good thing for Minnesotans, right? They're getting coverage. And then the second thing is that 413 million included the additional federal pass-through funds from the enhanced subsidies that are part of the American Rescue Plan. We've since updated our assumptions because it doesn't look like the federal government will be extending those enhanced subsidies.
So, Deputy Commissioner, if we request a new fiscal note, the numbers then you would be giving the folks would be relative to these same numbers you're giving here, the 236 and the 276 or the 512.
Chair Dahms, yes, that's correct.
That's what I was curious. Questions for any other members have any questions? Senator Matthews.
Thank you, Mr. Chair and Deputy Commissioner. So I'm hearing that an assessment would be about negative 18% on the premiums and negative 20% on the general fund. Why is that?
Deputy Commissioner?
Chair Dahms, Senator, I'm sorry, can you just ask your question one more time or a slightly different way? Just want to make sure I'm answering.
Senator Matthews?
If I'm hearing you properly, it sounds like an impact on the assessments will be in the range of like a minus or negative 18%, but there's a different number impact on the general fund. Trying to see if I'm hearing that correctly or what, if there's a discrepancy that I'm missing there.
Senator Rasmussen?
Thank you, Mr. Chair, and thank you, Senator Matthews, for bringing that up. And I think if I'm hearing you right, Senator Matthews, you're talking about the impact on premiums. And if we go with the path that the governor's proposed, it would reduce premiums by 18% versus if we go with a proposal we'll be hearing later today, the estimate is that that will reduce premiums by 20%. And I assume, Assistant Commissioner, that the difference there is because we're taxing insurance premiums. And so that makes the governor's plan have less of a reducing impact on the overall healthcare costs. Is that correct?
Deputy Commissioner?
Chair Dahms, yes. Senator Matthews, yes, that's correct. So the assessment would just have an 18% impact on premiums versus if you pay for it out of the general fund, it's about a 20% impact.
Senator Matthews, follow up. Any other questions? Seeing none, thank you, Deputy Commissioner. We appreciate your presentation and appreciate your coming in.
Thank you.
Senator Dahms, thank you for bringing the first bill this session to the Senate Commerce and Consumer Protection Committee. Would you like to move your bill before the committee today?
Yes, Mr. Chair, I'd like to move that Senate File 33-3 be moved and re-referred to Health and Human Services.
Thank you, Senator Dahms. And I understand you have an author's amendment that you'd like to offer at this time.
We have an author's amendment that numbers 33-3A-3. And what the author's amendment does is gets my bill in the order that I would like to present it. And if we take a look at the author's amendment, the first part of the author's amendment is put in after line 1.5 on the actual bill. And what that does is it lines up the bill with the session laws that we've had in the past. So that lines that up with that. Then we get to the bottom end of that amendment. It refers to page 1, line 11, and it just changes the word "the" to initial. The same on line 12, and then on line 14, it gives some more language on the submission of the application.
Thank you, Senator Dahms. So Senator Dahms moves the A3 amendment as an author's amendment. All those in favor say aye.
Aye.
Opposed, say no. The A3 is adopted. Senator Dahms, your bill's in the shape you'd like it. Please proceed to explain your bill.
So the bill is really a pretty simple bill. What the bill does is it talks about the continuation of the state innovation waiver and talks about when the commissioner must submit the application for the next waiver, and that's the 1332 waiver. The 1332 waiver is a waiver that allows the state of Minnesota to receive some funds back, and there's two parts to that waiver, and receive some funding back that has been taken away from the state, because as you reduce the premium, the amount of money that you get from the state reduces. So this would make up for that. So when we were talking earlier about numbers and stuff, the waiver that's projected for 26 and 27 is about $129 million. And that is part of the numbers that we were talking about. Now, my 413 million was a number that we plugged in because when we put this together, the latest number we had was the last fiscal note that we had. Under the current fiscal note, they use the 413 also, and so we will be requesting a new fiscal note now that we have the new numbers. So I would also like to do a oral amendment, Mr. Chair.
Yes, Senator Dahms, please state your oral amendment.
On the bill, on line 116, it would change the 413 million to 512 million. And an explanation on that, the 512 million is the number that the governor used in his budget, and it's the number that we saw in the presentation today, and that would make up the cost of the reinsurance for that 2-year period.
Thank you, Senator Dahms. Can we have council restate the oral amendment, please?
Yes.
Thank you, Mr. Chair, members of the committee. The oral amendment would read, Senator Dahms moves to amend Senate file number 333 as follows. Page 1, line 16, delete 413 million and insert 512 million.
Thank you, council. Thank you, Senator Dahms. Any member question or discussion? Seeing none, all those in favor say aye.
Aye.
Aye. All those opposed say no. The oral amendment is adopted. Senator Dahms.
And Mr. Chair, that gives us really what this bill is about. It talks, again, it talks about when we have to apply for the innovation waivers to make sure that we have them done in time in order for the next time we would be implementing this, and then to transfer the funds. And this bill requests it to be transferred from the general fund. So with that, I'll open it up for questions, Mr. Chair.
Thank you, Senator Dahms. And we do have a list of testifiers. And so if I could have Dan Andreessen from the Minnesota Council of Health Plans come to the table, you'll be first. And then if we could also have Lisa Talcott from the National Association of Benefit and Insurance Professionals make her way to the table, you're on deck. Mr. Andreessen, please introduce yourself to the committee and proceed with your testimony.
Mr. Chair, members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans. We represent the nonprofit insurers here in the state, which includes Blue Cross Blue Shield of Minnesota, Health Partners, Medica, Sanford Health Plan, and UCare. Thank you for the opportunity to testify today in support of Senate File 333. Minnesota's reinsurance program has been a success since it began in 2018, and we urge support to continue funding the program after this year. As the Deputy Commissioner mentioned, this is a state and federally funded subsidy program for Minnesotans who buy insurance on their own because they don't have access to insurance either through an employer or a government program. The program is based off a former federal reinsurance program under the ACA to lower premiums by paying a portion of the high-cost medical claims, a cost that otherwise must be built into premiums. Reducing premiums results in more Minnesotans being able to afford insurance, and maintaining coverage. When Minnesotans have access to health insurance coverage, they're more likely to receive preventative services and to seek care before a problem becomes an emergency. Now, the state uses an attachment point model, meaning that the program only subsidizes 80% of enrollee claims that fall between $50,000 and $250,000. This means that all claims below $50,000 and above $250,000 are completely paid by the health plan. Eligible claims are submitted quarterly by the health plan to the Minnesota Comprehensive Health Association, and the Department of Commerce ensures that these funds are being used appropriately. Once these claims are verified and the matching federal funds are received, the state makes payments to health plans 12 to 18 months after that health plan had already paid the provider for that claim. Now, even though this payment is retrospective, since health plans know the subsidy is coming, they're able to account for this in their rates and lower premiums. Now, these transactions are summarized in quarterly and annual reports that are published publicly on the association's website by actuarial firms. This is just the reports for the 2023 plan year. And in your packets is the most recent Q3 report for plan year 2024. So Reinsurance is one of the most audited programs in the state, and everything you'd want to know about how this program runs is in these reports. These reports show how much money is being spent and how it's being spent. This includes breakdowns on reinsurance payments by health plans and their products. You'll see in the report that right now only nonprofit insurers are receiving reinsurance funds. The report also breaks down payments by metal level, plan type, exchange status, claim spend, geographic area, and which chronic conditions are being subsidized. High-cost medical claims for over 4,200 patients were subsidized in 2023, including people living with diabetes, asthma, rheumatoid arthritis, heart conditions, cancer, and more. Now, we hear a lot of misinformation about this program. We hear assertions that this is a bailout for health insurance companies. This is a subsidy program for patients who keeps money in the pockets for your constituents who would otherwise be paying in premiums. The money passes through health plans because we're the ones processing the medical claims. The reinsurance funds are being used to pay medical claims for chronic conditions. This is money that's going to the endocrinologist who is treating somebody with diabetes. It's going to the oncologist who's helping somebody battle cancer. It's the cardiologist treating somebody with a heart condition, or the respiratory therapist helping somebody with asthma. Reinsurance subsidizes this care, and as a result, premiums are lower for everyone. An analysis of Minnesota's reinsurance program by the Centers for Medicare and Medicaid Services in 2021 showed the program has been a resounding success. It concluded premiums have been 22 to 36% lower than they would have been without reinsurance, resulting in 88,000 Minnesotans having insurance that they may not otherwise have. The advantage of the program is it doesn't affect someone's healthcare experience. The operation is seamless to patients, and those with high healthcare costs don't have to fill out new paperwork or enroll in a special program. Now, as was mentioned, we are in a unique situation this year with reinsurance funding ending at the same time as the federal ARPA subsidies. If Congress doesn't extend those and reinsurance ends at the same time, we're going to see significant disruption in the individual market. Modeling performed by RAND showed that these two programs ending at the same time could result in premiums going up as much as 50%, resulting in almost 93,000 Minnesotans losing coverage. This is on the heels of MNsure announcing last week that we had record enrollment on the exchange in the individual market, helped in large part because of the reinsurance program. I do want to mention regarding assessments that health plans are currently being assessed. There are several taxes that health plans currently pay. If you have if your line of business is just in commercial insurance, you're paying a 2% premium tax. If you're an HMO, you're paying a 1% premium tax and a 0.6 surcharge. Two of those three, the premium tax and the surcharge, both go into the general fund. And the general fund is in part paying the reinsurance payments. So I think you can make the argument that health plans are already being assessed to run the reinsurance program. If you wanted to make sure that that money is directly going there, you could reallocate the money from the general fund to the premium security account. As I conclude, I wanted to highlight in your packets that there is a fact sheet which summarizes comments made in my testimony. There's also 2 letters of support in your packets, one from business groups, providers, and insurers, and another one from patient advocacy groups. The council thanks Chair Dahms for his authorship of this bill. and ask for your support. Thank you.
Thank you, Mr. Andreessen. Ms. Talcott, would you please introduce yourself to the committee? And I'll also ask that Ann New Brindley with the Minnesota Business Partnership, you're up next. Ms. Talcott.
Mr. Chair, committee members, good afternoon. My name is Lisa Talcott, and I am the president of the Minnesota chapter of the National Association of Benefits and Insurance Professionals. And I'm an independent insurance agent serving individual and small employer customers here in the Twin Cities. I'm here today representing the Agents Coalition, which includes the 4 professional agent associations in Minnesota, including the National Association of Benefits and Insurance Professionals of Minnesota, National Association of Insurance and Financial Advisors, the Professional Insurance Agents, and the Big I, Minnesota. Collectively, we represent the over 54,000 licensed insurance agents throughout Minnesota. Our agents represent 2.25 million Minnesotans covered by the private market, and we work closely with both group and individual market consumers on a daily basis. We strongly support the extension of the reinsurance program, and we thank Chair Dahms for his authorship of the bill, as well as Chair Klein and Senators Seeberger and Duckworth for co-authoring this critical bill. The individual marketplace is not only where individuals and their families get coverage when they do not have access to employer-sponsored coverage. It is where entrepreneurs get their coverage when they start a new business, and it is also relied upon by individuals between jobs and early retirees. When the ACA moved 27,000 sick people from the MCHA program to the individual market, the premium impact drove huge price increases, and carriers were leaving the individual market. And consumers, our clients and your constituents, were getting headline-making double-digit premium increases. Without this program, it was uncertain if any carriers would have chosen to continue offering coverage to this market segment. We are pleased that Governor Walz included the extension in his budget. We do, however, have significant concerns about the new MCHA tax. Instead, we encourage you to consider much broader funding sources, including the general fund or healthcare access fund, that reflect the benefit of this program to all Minnesotans. We supported the creation of this plan, and the premium security plan that you passed in 2017 is working, and it needs to be continued and made permanent. When the program was first implemented, according to the Minnesota Department of Commerce, this plan resulted in premiums being 20% lower in 2018 than without the plan. All of the benefits of this program go directly to consumers in the form of lower premiums, as shown through the rate filings of the carriers. No funding really goes to the bottom line of the insurance carriers, since they can only make a claim for actual medical bills and are then reimbursed by MCHA within the narrow parameters of this plan. They cannot receive reimbursement for their overhead and administrative costs. Please support this bill to help keep the stability in this vital program for individuals and families. Thank you.
Thank you, Ms. Talcott. Up next, we have Ann New Brindley with the Minnesota Business Partnership. Ms. New Brindley, would you please state your name for the record and proceed with your testimony?
Thank you, Mr. Chair and members of the committee and staff. My name is Ann New Brindley, and I am the Health Policy Director for the Minnesota Business Partnership, and it's really fun to be with you today. MBP represents over 100 business leaders and executives who employ nearly 500,000 Minnesotans across a wide range of industries across the state, and together they contribute significantly to our state's economy. As you know, Minnesota consistently ranks ranks among the top states for healthcare quality and has one of the lowest rates of uninsured in the nation. We rank 4th in the country for employer-sponsored insurance and 6th for employer contributions to healthcare. This strong healthcare foundation is supported by our headquartered economy and world-class healthcare systems. MBP members care deeply about affordability, access, and equity in healthcare, and we appreciate the opportunity to testify in support of Senate File 333. The Premium Security Plan has been instrumental in stabilizing Minnesota's individual insurance market, and without its extension, premiums could increase by 25% or more, leaving tens of thousands of Minnesotans without affordable coverage. Such a significant rate hike would not only put coverage out of reach for many Minnesotans, but it would also likely lead to substantial budget shortfalls for healthcare providers and drive up insurance rates in the commercial market, creating other unintended consequences and instability in the healthcare ecosystem. The Minnesota Business Partnership is committed to supporting affordable, accessible healthcare for all Minnesotans and a stable healthcare ecosystem, and the Premium Security Plan plays a crucial role in achieving those goals. Thank you.
Thank you, Ms. New-Brindley. Up next, we have Ben Baglio with the Minnesota Nurses Association. Welcome to the committee. Please introduce yourself and proceed with your testimony.
Good afternoon, Mr. Chair, committee members. My name is Ben Baglio. I'd like to first thank you for allowing me to testify today. M&A represents over 22,000 registered nurses that work directly at the bedside with patients across hospitals in our state. While caring for patients and families, nurses witness firsthand not only the barriers that patients face to access services and supports through our chronically understaffed hospitals, but also the unfair treatment and unnecessary barriers created by the same profit-driven health insurance companies that also regularly deny claims for even the most vital and medically necessary treatments. This is why M&A not only supports establishing a state-administered single-payer health system and eliminating the unnecessary insurance middlemen altogether, but it is also why we continue to oppose using even more taxpayer dollars to further enrich the very industry that has been pillaging our healthcare system, raking patients through the coals, and denying claims as often as their new algorithms tell them they can. Over $1 billion in state taxpayer dollars have gone directly to these big corporations in less than a decade, and we've heard how that's how they'll keep rates low. If the legislature is even consider reauthorizing any form of reinsurance, M&A strongly urges legislators to require it to be paid for fees on insurers, the ones making those record-breaking profits we have all read about, and not on the taxpayers of Minnesota. We'd also ask that any extension be contingent on protecting funding for Minnesota Care, and that those protections be codified into law to protect Minnesotans who rely on those programs for coverage. Minnesota does not need to continue to be a national outlier for how much public dollars our legislature shells out to the private insurance industry, regardless of which of those massive corporations happen to be headquartered in our own state. And we hope the legislature will change course this time around and actually hold insurers accountable for the role they play in increased costs and in ridiculous rates of claim denials. I'll just conclude with this. Given public sentiments right now around the health insurance industry and how Americans are feeling about the amount of money these guys are making off the backs of sick and dying people, I'd ask you to all think long and hard about whether or not your own constituents would support you using their tax dollars for yet another big cash giveaway to the health insurance industry. Because that's exactly how this will be viewed, that's exactly how this will be remembered, and we ask you to please stop kicking the can down the road. Thank you.
Thank you, Mr. Baglio, for your testimony. Up next, we have Kate Lynch with SEIU Healthcare Minnesota and Iowa. If you'd please proceed to the table, introduce yourself to the committee, and proceed with your testimony. Thank you.
Good afternoon.
Ms. Lynch.
My name is Kate Lynch, and I should have said, I'm sorry, Chair Dahms, Vice Chair Rasmussen, Chair Klein, and members of the committee. My name is Kate Lynch. I work as an LPN at Health Partners. I live in Roseville. I'm here to testify on behalf of my union, SEIU Healthcare Minnesota and Iowa. I'm a vice president of my union, and our union represents about 50,000 healthcare workers around the state at hospitals, clinics, nursing homes, and self-directed home care. We oppose the current version of Senate File 333. If the legislature decides to continue with reinsurance, then we strongly recommend that you fund the program through some kind of industry assessment. The governor proposed a mechanism like this in his budget. We think it is far superior because it would preserve scarce general fund dollars for the important health care policies. I think we all agree that the status quo was broken. Health insurance companies are deeply unpopular because so many people have had terrible experiences with them when facing a health crisis. At a time when people are so angry at the health insurance system, we cannot solve the problem by giving more of our taxpayer money to the people who build and profit from the system. As a healthcare worker, I see too many of my patients, including my own son, who recently aged off my plan, that are forced to buy private health insurance plans and with heavy cost sharing. This is especially true for those who buy the individual insurance plans. I work in pediatrics and in family practice, and every day people call in about serious health issues. I recommend that they come to the clinic so that we can diagnose them or treat what is going on. And every day, a few respond, I can't afford the copay or the deductible is too high. The companies that built this system don't deserve a handout from our state's general fund that could go to regular Minnesotans, and we should look at ways to get financial relief to patients directly. We all want to make health insurance affordable, but we will not solve the problem by giving over $400 or even $500 million to the very people who profit the most from the current system. Insurance companies have no incentive to fix the problem that they cause. This is why most other states that have reinsurance program fund is less through general funds and more through some kind of industry assessment. More importantly, we do not have what could be $512 million to hand over to insurance companies unless we cut from other critical priorities. We all know we will face choices when you put together a budget this year. If you spend over $500 million on a handout to greedy insurance companies, will you be able to protect the current Medicaid provider rates, which are already too low, especially in mental health services? Will you be able to make critical new investments in long-term care funding for nursing homes and home care? It is not just blue states like Maryland, Oregon that have funded their reinsurance programs through an insurance-free, but also states like North Dakota, Iowa, Montana. That is because we all face the consequences that come from this totally broken system. Across the country, legislators from both parties agree that funding reinsurance through an industry fee is a smart way to protect their general fund. In many states, there is bipartisan agreement that we should protect critical investments in education and human services, and I hope Minnesota can do the same.
Thank you, Ms. Lynch, for your testimony. Up next, we have Dr. Katie Guthrie with Isaiah. Dr. Guthrie, welcome to the committee. Would you please state your name for the record and proceed with your testimony?
Chairs, members, thank you for the opportunity to testify. My name is Catherine Guthrie, and I live in Eagan Senate District 52. I am a family physician. I've been practicing in Minnesota, both in rural and urban settings for 46 years. I'm a leader, as you heard, with Isaiah Faith in Minnesota. I'm here today to express my deep concern about SF 333 in its current form. No matter our background or what corner of the state we come from, Minnesotans all deserve access to high-quality, affordable care. The human tragedy that comes with lack of health care is something that my colleagues and I witness daily. Over my 48 years as a Minnesota transplant, I have appreciated how our taxes are used to improve all our lives in many ways. My concern with SF 333 stems from my concern that in its current form, it will jeopardize that improvement for many. Since 2017, we have spent $1 billion from the general fund on what was initially proposed to be a temporary stopgap, as you've heard. This fund assists about 2% of Minnesotans who purchase health care insurance on the individual market. According to 2023 data from SHADAC, 18 states have reinsurance programs which vary in what is covered and how it's paid for. Minnesota is an outlier in both dollars spent overall and in how much we subsidize these corporations from taxpayer dollars. Only one other state, Maryland, paid more overall than Minnesota. Maryland, however, funds their program primarily through a 2.75% state assessment paid by broadly defined health plans of all types based on annual net premiums. Only two other states, this is data from 23, so a little different than you may have heard. The only other two states that were funding reinsurance through their general funds at the time were Wisconsin and Georgia. We paid more, $237 million more than Wisconsin and $179 million more than Georgia in that year. SF 333 as written would pour another $512 million into the pockets of the insurance industry. That is nearly all of the projected budget surplus for the coming biennium, which turns into a shortfall in the following years. In a time when we're facing potentially disastrous federal cuts to healthcare, childcare, food assistance, housing, and other essential programs, it is inconceivable we would be prioritizing a subsidy to health insurance companies from the general fund. In addition to the budgetary impact of this direct subsidy to insurance companies, we are very concerned about potential implications for federal reimbursement to Minnesota Care. Under the first Trump administration, Minnesota took a $500 million hit to federal reimbursement. This is because the so-called reinsurance programs lowered the premium rates on which federal reimbursement is based. While this problem was fixed in the Biden administration, there is no guarantee that that fix will remain in place in the new Trump regime. We understand there's a lot of concern about health insurance premiums spiking next year. I share that. With the coming expiration of the enhanced federal premium tax credits, they will likely rise to unaffordable levels, pushing many people off of health insurance coverage altogether. We hope that each of you, regardless of your party affiliations, are joining us in strongly advocating with our congressional delegation to avoid that. But the outlook in Washington, D.C. is uncertain. Reinsurance programs have reduced premium costs by variable amounts, 20% being the highest amount, relative to states without reinsurance programs. But they have not demonstrated any consistent impact on insurance availability across the states employing them. In conclusion, it's time to say enough is enough. Let's stop pouring public money clearly needed for other issues at this time into the pockets of the healthcare industry. Minnesota can and should learn, as the proposed by Governor Walz and explained by Assistant Commissioner Dreyer, to follow the path of all of the other states that have reinsurance programs and spend the time to develop a fee structure that includes a structured fee tax or something similar for the insurance companies as they do in the other states. Thank you.
Thank you, Dr. Guthrie, for your testimony. Is there anyone in the audience who would like to testify on the bill? Seeing none, we'll turn to member discussion. Senator Klein.
Thank you, Chair Rasmussen. Members, first I want to just draw attention to the author's amendment that we approved, the A3, just so members are aware. We honor author's amendments and give them our supportive votes universally, but I want to make sure everyone is fully aware that a provision within that amendment means that we will no longer seek legislative approval to re-up the waiver every 5 years as we have historically done. It will put that in the power of the commissioner and put it on auto drive. To Senator France's earlier point about how this was initiated as a temporary bridge, and now with this bill in its current form, it will become the solution and an ever more expensive solution year over year to the future. Next, I want to address the speakers from Isaiah, whose work I admire and uphold and believe in. First of all, we have gotten your emails. Thank you for them. Second, I was prepared to include in the Commerce Omnibus last year the public option, which I believe was your top healthcare priority. And that proposition was defeated, not just by Republicans, but by Democrats as well. Frankly, we are now in a place where we no longer have the time or the electoral power to do that option again. we are stuck with either reinsurance or a direct subsidy to the healthcare market to make sure that people in the individual market don't experience intolerable increases in their premiums next year. And again, these are human beings. These are farmers, they're self-employed child workers, they're small business owners in our communities, and we simply cannot allow them to suffer that increase. So I will be voting yes if the motion is, as I understand it, to move this bill to the Health and Human Services Committee. But before we go to that vote and finish up our commentary, Mr. Chair, I would like to offer the A4 amendment.
Senator Klein moves the A4 amendment. I believe it is in members' packets. Senator Klein, to your amendment.
Thank you, Mr. Chair. The A4, and I'll tell the committee in advance, the A4 does not have the votes to be sustained, and we're withdrawing it rather than subject it to a negative vote. But essentially, we've agreed here that the issue before this body this year is how to pay for reinsurance, which we believe we may have to do. The A4 increases the provider tax on pharmaceutical distributors. Our current provider tax in the state of Minnesota is 1.8%, which applies to a broad array of providers, doctors, nurses, et cetera, clinics, but also applies to drug distributors within the state of Minnesota. The A4 would increase that 1.8% on drug distributors only to X, whatever number it is, and the overage above the 1.8% would be dedicated to the premium security account to pay for reinsurance. When I thought of the concept for this bill, if we look at the healthcare delivery system as a whole, and people who are trying to buy insurance on the individual market are clearly at the bottom of the barrel. They're scraping up hard-earned dollars just to keep covered. And other segments of the industry are hugely profitable. And those two segments would be for-profit health plans, which I believe the governor's proposal targets in part, and also pharmaceutical manufacturers and distributors and PBMs. The A4 tries to tax PBMs, distributors, and pharmaceutical manufacturers to pay for our individual market farmers and self-employed workers. Before I withdraw it, I'll expose it to comments from the committee. I anticipate there will be some complaints about how this is a new tax. And let me just answer that in advance by saying, I think if you ask, in the current form of the bill, it pays for reinsurance out of the general fund, which is income tax dollars and corporate tax dollars, gas tax and sales tax. I think if you ask most Minnesotans if they would rather pay for the individual market through those sources or by a tax on PBMs and pharma, they would choose the latter. And that's what the A4 attempts to do, Mr. Chair.
Thank you, Senator Klein. Member discussion to the A4 amendment. Senator Howe.
Thank you, Mr. Chair. And I think what most folks have to realize here is that when you increase taxes on any business, any corporation, anybody, where that tax ultimately gets paid is by the consumer. Those businesses pass those taxes right back down the line to those of us that consume their products and their services. So if you think you're taking it out of their bottom line, it's not going to. It's going to come out of our back pockets as consumers because we pay those taxes. Thank you, Mr. Chair.
Senator Wickland to the A4 amendment.
Thank you, Mr. Chair. I just wanted to express my support for the A4 amendment. I think we do need to explore a way to bring if we are going to go forward with reinsurance, bring it forward in a way that removes the general fund, which is as Senator Klein mentioned, is taxpayer dollars and hundreds of millions of taxpayer dollars that would go to the program. I think the trying to assess the entities that Senator Klein has proposed is one way to defer and put that onto a segment of the market that is experiencing a great deal of profit, and I think it would be a more just way to fund the program. Thank you.
Senator Seeberger to the A4 amendment.
Thank you, Mr. Chair, and thank you, Chair Klein, for your efforts to find creative solutions to address the reinsurance issue and the significant costs that it brings. I support efforts to find ways to keep the costs off the backs of the taxpayers. I think that looking to the entities that can afford to support the cost of a program like reinsurance is wise. I think if we look at wholesale pharmaceutical companies, certainly it would seem to me that those entities have the ability to bear this cost. And while I don't think it's equitable to build in cost savings for taxpayers so that they pay it on the other end, which is the argument against the A4 amendment, I do think that finding creative ways to take the cost off the backs of the taxpayers is the way that we need to start focusing on how do we fund this project. So thank you, Chair Klein, for this. I support the concept. I wish that we had more creative thinking to figure out ways that we could fund this program.
Any further member discussion to the A4? Senator Dahms.
Well, thank you, Mr. Chair, and I'd just like to weigh in on this. I know we're not going to be voting, but if we were voting, I would look at this as a non-friendly amendment. And the reason I would look at it that way is, again, as Senator Howe said, we're just going to be shifting the cost. And in shifting that cost, it's going to raise the price of the product that they produce. The other piece of this is if we look at the general consumption of pharmaceuticals, if we look at the age bands, you get into those old age bands, and they're consuming a lot of those pharmaceuticals. So what we're really doing is we're shedding this off, because that's where the price, so those prices go up, so we're shedding it off to the elderly. And I think there's better ways of doing that.
Any further discussion before we go back to Senator Klein? Senator Klein to the A4.
Mr. Chair, I withdraw the A4.
Senator Klein withdraws the A4 amendment. Next on my list, I have Senator Duckworth to the bill.
Thank you, Mr. Chair. I appreciate it. And if it's okay, I have just a couple of questions for the bill author and then some comments, if that's okay.
Senator Duckworth.
Thank you, Mr. Chair. I appreciate it. And thank you, Senator Dahms, for bringing this bill forward. I want to make sure I understand what it's trying to accomplish in the simplest words possible. Essentially, what your bill does is it takes the money that was pulled out of this account a couple years ago and essentially puts it back without instituting a new tax with no ceiling in perpetuity. Is that correct?
Senator Dahms.
Thank you, Mr. Chair, and Senator Duckworth. In essence, that is correct. Now, we did take out, back in 2023, there was a transfer of $275,775,000. And then again in 2024, there was another transfer of $8,830,000. So there was $284,605 transferred out of that account. Now, there's a difference in agreement as to where that money came from. Some people say, well, it came from the fact that on the 1332 waiver, there's two pieces of that waiver. And the first few years, we did not get the second part. After that, we started getting the second part. So some of that waiver, we started getting the waiver when we went into the second 5-year term of the 1332 waiver. So when we started to get that, that increased the pass-through, so that's some of it. But also, if you take a look in history and take a look at the numbers that we've been using for reinsurance, the numbers are always higher than what actuality ends up being. So a lot of this money was put in this fund for reinsurance. But not all of that money was used for reinsurance because our numbers were lower, participation and cost. And that's been kind of typical going through the history of this. So that money really should have stayed there. If you really wanted to get technical, you could have probably taken the pass-through out, but the balance of it should have stayed there because that was money put in order to make sure that we met the requirements of the 1332 waiver and use the numbers that the Department of Commerce assigned to it. So that would be, so some of this money should have still been in there. But if we even put the $284,000 in, we'd still be looking at a couple $100 million that we would be needing to put in there. So, but your assumption is correct.
Senator Duckworth.
Thank you, Mr. Chair, and thank you, Senator Dahms. I appreciate that. And I should have said earlier that I appreciate the testimony from everybody that came here today. The irony of this is I think we're all trying to accomplish the same thing. We've just got a couple different ways of getting at it. I would imagine, Senator Dahms, that part of the reason, or probably the main reason, you'd like to see this money returned to the fund is to keep insurance premiums from Minnesota as low as possible. Would that be a fair assumption regarding your bill?
Absolutely.
Senator
We have
Dahms.
to take a look at, Mr. Chair, sorry about that.
Senator Dahms.
Duckworth, absolutely. And we have to take a look at the history of this process. Back in 2017, when the Affordable Care Act came out, we had several counties that had no insurance providers. People would not sell insurance in those counties. We had several of those. And so, and that was really a struggle. So in 2018, this program was implemented, and when we implemented this program, every county had at least 2 insurance providers, many of them had 3. And if we look at today, every county has at least 2 insurance providers, and many of them have 3. And the reason they're there is because of this program. The individual market is a tough market. And so by putting the funds in and by constantly funding it, it gave our counties opportunities to have people that could buy insurance, opportunities for people to buy insurance from the insurance providers.
Mr. Chair.
Senator Duckworth.
Thank you, Mr. Chair, and thank you, Senator Dahms, for that. Is it also fair to assume that should the governor's proposal move forward, which would implement essentially a new tax on insurance providers, I think to the tune of what was estimated at $500 million over the course of the next few years, is it fair to say that that would likely result in an increase to insurance premiums or payments for Minnesotans in your estimation?
Senator Dahms.
Thank you, Mr. Chair and Senator Duckworth. Yes, it will. One of the things that they're saying the governor's looking at is he's expanding the base where they could draw the money from. But even in expanding that base, the premiums are still going to go up. Not only are they going to go up in the reinsurance area, they're going to go up in all the other areas that they're taking that money from. When you get to health insurance and get into insurance, there are requirements and there are rules and regulations as far as profits and all of these things. And that's meant that those are watched by the Department of Commerce. So if you are going to start increasing the cost, you're going to increase the rates.
Senator Duckworth.
Thank you, Mr. Chair, and thank you, Senator Dahms. I appreciate that. And I'm not going to try to enter the contest of who's been around long enough to remember all the history of these programs, but I have been around long enough to remember at least the last couple of years. And I may have had a little bit of fun earlier with my language when I said that the funds were robbed from the account, but that was intentional. Because if I recall at the time that the funds were, maybe I'll use the word siphoned from the reinsurance account or fund, I think the state had about an $18.5 billion surplus. And I think we also increased taxes by about $10 billion on the people of Minnesota. And then we came back for the $300 million that was sitting in the reinsurance fund, which has left it depleted today. And all of that money was used to increase government spending by about 40% or $20 billion. So when we talk about governing in a way that keeps costs low for the people of Minnesota, not only as it relates to insurance, but property taxes, the cost of education, you name it, I think we have to have memories that are a little bit longer and truly holistically look at how we're managing government, its expenses, taxes, and the cost of living for the people of Minnesota. So I appreciate the fact that your bill has taken a stand to say we're going to put that money back to keep insurance premiums as low as possible. And oh, by the way, we're not going to allow it to happen again, because I think there is some fair criticism that a more long-term solution is needed. And I think we keep renewing or funding reinsurance. Maybe it's time we start to admit that that might be the long-term solution. And by ensuring that money that's put in that fund stays there is how we fix it. Thank you.
Senator Wickland to the bill.
Thank you. Thank you, Mr. Chair. Senator Dahms, I just have one question, and then I have some comments about the bill. I'm hearing people say, you know, that this is a program that works. It's a success. I would say that I see it as a program that has provided a measure of cost stability, but I think it has a lot of deficiencies as well. And I think that what I see from your amended bill that we've adopted, it sets in motion that that process will continue without further interference from the legislature. My question, though, is, it sets in motion a process that would allow the waiver applications to happen when needed in an ongoing manner, but how would we pay for that? The bill contains money for plan year 2026 and plan year 2027, so.
Senator Dahms.
Mr. Chair and Senator Wickland, that's a good question. First of all, I want to clarify, this does encourage the applications for the waivers when needed. However, you can get an application, but if you don't fund it, nothing happens. So there is a mechanism down the road, if somebody, if another legislative, in another legislative era, 2 years from now, if the legislators don't want to fund this, the program stops existence. It has to be funded. What the waiver does is make sure the waivers are in place in case it wants to be funded.
Senator Wickland.
Mr. Chair, Senator Dahms, I guess from my experience in how waivers are developed and the application process, I would say that we would not achieve a successful waiver without having the state funding allocated or committed in some way. And so I'm not sure that we would, in 2 years, if this was in place and the waiver application process proceeded, I think the Department of Commerce could comment more specifically about that, but I do think that there would be an issue with a waiver being successful without having action taken by the legislature to actually fund the program.
Mr. Chair, Senator Wickland,
Senator Dahms.
with what you've just said, I think you drive my point home. If, in order to do a waiver, you have to show you have it funded, where would the funding come from if the legislative body didn't authorize it? They would have to, then they would have to authorize the funding before the waiver could be placed.
Senator
Mr. Chair,
Wickland.
Senator Dahms, I think then we're in agreement. You allow for department to proceed with waiver application process.
Correct.
But I don't think that the process could be completed without the legislature taking further action. And so if the perception is that this bill would somehow remove some of the discussion needed and the work that the legislature needs to do to decide on the funding and the waiver, I'm not sure that it accomplishes that, because I think it still has to be revisited in 2 years. I don't have other specific questions about the bill right now, but I just wanted to make some comments about, I think reinsurance is a way that it has provided some cost stability for people in the individual market, and I think that's important, and I think we are in a difficult place right now in terms of finding a way to provide some premium cost stability for the individual market members. I think that the reason I have concerns about reinsurance is that it isn't a way to help bring down costs if we're looking at healthcare costs. It's a way to keep premiums from rising as much as they would have if we didn't have reinsurance in place. And it does nothing to control the cost of care, healthcare for Minnesotans. And I think that we should be trying to examine, are there better ways that we could be spending, whether it's $500 million of general fund taxpayer dollars, or assessing, what we think is a more appropriate group to pass the assessment on. I think we need to be clear that it's a lot of money, and we aren't addressing the rising rate of healthcare costs by doing this. So I think under reinsurance today, another issue I have with it is that we talk about premium stability for people, But many people who buy their plans on the insurance, on the individual market, they can't afford to use their plans. The premiums are one part of the cost, but out-of-pocket costs for deductibles and, the full out-of-pocket costs have risen so greatly that many of the people buying in this market can't afford to use the plan that they buy. And I think we haven't done enough to address that. And that was why we worked hard over the past 2 sessions on the public option bill, because it was going to be a way to help to address that issue. I guess also I just wanted to say that in terms of this bill, it doesn't really address all the implications for MNsure. Some of their funding needs to be addressed and is impacted by reinsurance and the reduction in rates. And so when it comes to the Health and Human Services Committee, that's one thing that I think we do need to talk about is how that's impacted and how do we create language that would formally address that. So I guess in conclusion, I just want to say I think, we're moving quickly on this bill because we know that in past years when we've had to address this, there's been an urgency to address it early in session. But I don't think we should rush our decision-making, and especially not rush our decision-making because we've already done this before. I think we owe Minnesotans a real comprehensive discussion before we commit hundreds of millions of dollars, and we know it's a tight budget year. And so I'm looking forward to having further discussions in the Health and Human Services Committee on this topic and addressing concerns, talking about possible alternatives, and then just having a greater conversation about healthcare affordability. So I look forward to that, and thank you, Mr. Chair.
Senator Latz.
Thank you, Mr. Chair, and Senator Dahms for bringing this bill forward as a proposal to address the problem with the insurance market here. One thing I just want to note before I have a couple questions for the author. In 2023, the money that was transferred out of the fund that was involved here was transferred because of market changes and assumptions and claims experience. So it was no longer needed to meet the terms of the deal that Senator Dahms was directly involved in crafting and agreeing to in passing. So since the money was no longer needed to fund that agreement, the money was available for other purposes. But my first question for Senator Dahms is, how does this bill address the long-term issues in the insurance market?
Senator Dahms.
Thank you, Mr. Chair, and thank you for the question, Senator Latz. As far as the long-term, right now, we haven't come up with anything that works any better. We talk a lot about it. We discuss how it's going to be paid for. We talk about this, but every time when it comes time to do the waiver, every time it comes time to do something different, we don't come up with any solutions. We don't come up with anything different. We hear about the public option. Public option doesn't mean you're going to save any money. Nobody's been able to show me how they're going to save money by going to a public option. If there is a way of saving money, we need to look at it. But so far that I have seen, nobody's come forth with anything, and we've all talked, we've admitted this. We have not come forward with anything. And just because I carry the bill and support reinsurance doesn't mean some other people can't get involved and figure out new ways to drive down the cost of health insurance. Adjusting premiums drives down the cost to the individual receiving the care. But I've never claimed that reinsurance drives down the cost of the care. It drives down the cost of the people receiving the care and makes it so that we have people that can buy insurance.
Senator Latz.
Thank you, Mr. Chairman, and Senator Dahms. I'm not an expert in this field, But my understanding is at least one value to a public option would have been to provide some competition in the marketplace, which is sort of a quintessential pro-capitalist approach to the market and to solving problems. And without the public option, the market is more consolidated with less competition. I know there were other parts of the public option bill, but that would be one aspect of it, which I thought was valuable. But it sounds like this bill is once again being offered as a short-term patch without any proposals or suggestions for how to address the long-term concerns. Since 2017, there's been this idea out there that some long-term concerns should be addressed, and we have the chief author coming forward now with another short-term patch. And we might again be in a position like we have been the last couple of times, is that this short-term patch is left as the only option because no one's willing either to agree to or take serious run at longer-term solutions. And as long as we keep passing the short-term patch, it just relieves the pressure for another 2 years, another 5 years to focus on long-term solutions to the problem, which I don't think is healthy in the long run for either the people in this portion of the market or Minnesota taxpayers altogether. Senator Dahms, you're an expert in the insurance industry. So I'm going to ask a question I think I know the answer to, but maybe you can help me understand it. Isn't it industry practice generally, I'm not talking only specifically here, but for reinsurance, isn't there a worldwide reinsurance market out there that underlying primary insurance carriers turn to, kind of like umbrella coverage, if you will, backup insurance in case they get so overwhelmed with claims, they've got a backup place to go to get covered so they aren't put out of business? I mean, I'm thinking in terms of, for example, my brother-in-law worked for Swiss Re for a number of years. He worked in Switzerland, and when the two towers in New York and the planes were all destroyed, Swiss Re happened to have the insurance coverage for all four of those entities, and my brother-in-law was directly involved in recapitalizing Swiss Re. So I know a little bit about it, but that's my understanding. And so that is typically industry funded. The insurance companies, to protect themselves, get a reinsurance backup plan, if you will. So why is it that that isn't an appropriate model for here in Minnesota rather than a general fund taxpayer paid for reinsurance program?
Mr. Chair,
Senator Dahms.
Senator Latz, that's a good question. The fact of the matter is, when you talk reinsurance, you talk property, casualty, and liability. I don't know of any medical reinsurers that reinsurance medical or health insurance companies. I'm not aware of any. And that's why states that want reinsurance do it as a state reinsurance program versus the private option, because I don't know of any reinsurance carriers. And in the property, casualty, and liability area, you're seeing that number of reinsurance carriers shrink quite frequently. I mean, that number is shrinking. When I first started in the industry, property, casualty, liability, when I first started in the industry, we had a fairly good number of reinsurers. Over the years, a lot of those folks have got out of the reinsurance business. And today, we probably have 3 reinsurance carriers in those fields. I don't know of any in the health industry. And that's why you see various states doing their own reinsurance program, because it's not available.
Senator Latz.
Thank you, Mr. Chairman. Senator Dahms, that actually really helps me understand, and I appreciate that. But then if it comes to the question of how do you fund a reinsurance program, why is it important for the public Minnesota taxpayers to fund it rather than the industry? If the state's willing to provide the reinsurance company, if you will, or program, why wouldn't it still be fair for the companies that would directly benefit from reducing the pressure or the exposure for them to be paying for that in the form of whether it's a pharmaceutical, provider tax or some other mechanism within the industry rather than coming out of the general fund?
Mr.
Senator
Chair,
Dahms.
Senator Latz, I think one of the issues is that healthcare is hard to project the losses. And so it's hard to do a reinsurance and understand the proper premium that would have to be charged. Comes property casualty liability, it's much more predictable. Now, with that said, stated in the last couple of years, that predictability has changed. Look at the fires in Los Angeles. That was probably not predicted. And if there would have been prediction there, it'd probably been much smaller than what it was. Health insurance is really hard to predict. There's several more influences that would influence the reinsurance underwriting for health than there would be for property casualty and liability. And I'm assuming that's one of the reasons that there's no carriers doing that, is because it's hard to do the predictability of it.
Senator Latz.
Thank you, Mr. Chairman. So there are some of us who might say the fires in Los Angeles were a little easier to predict, but that opens up a whole discussion about climate change. I don't think that we need to go down that road here. Let me understand this, Senator Dahms. Where does your bill get its money from?
General fund.
Senator Dahms.
Thank you, Mr. Chair. Senator Latz, general fund.
So then,
Senator Latz.
Thank you, Mr. Chairman, Senator Dahms. So the Minnesota taxpayers would pay for it, right?
Senator Dahms.
Thank you, Mr. Chair. And Senator Latz, yes, the taxpayers would pay for it. In the past, some of the money was taken care of out of the Healthcare Access Fund, which, but the taxpayers would, this is tax dollars, yes.
So,
Senator Latz.
Mr. Chairman, so I've got my own issues with the provider tax. Honestly, I think it's something probably the taxpayers as a whole ought to bear, not the providers themselves. Although there was a question raised about pass-throughs and whether there was a 100% pass-through. I don't think there's ever really a 100% pass-through. You impose a tax on an industry, maybe the industry will pick up some portion of it, and some portion of it, depending on their market, they'll be able to pass through, but probably not all of it. But setting that aside, if we're talking about the general fund paying for it, which current general fund expenditures would you cut in order to fund this $500 million bill?
Senator
Well,
Dahms.
thank you, Mr. Chair. And I can't say I would specifically cut this or specifically cut that. One thing I wouldn't do is I wouldn't do like the governor's doing. Puts out a budget and is shifting $804 million in 4 years down to the counties. He's shifting money for education down to the counties. I think with the amount of money that was spent in the last 2 years, if we could just clean up the fraud, this would be easily paid for.
Senator Latz.
Mr. Chairman, other than the polemics, I challenge you on the numbers. If you've got numbers on that, I'd love to see it. If you've got the numbers that would support that statement. But I think it's
What part of the statement you want numbers on?
Sorry, Senator Latz.
the amount of fraud that you're saying. If you can show me X number of dollars of fraud, and that would pay for this, I'd love to see that. But setting that aside for a moment, because that's not really where we're trying to go here, because we're looking forward. We're trying to look forward here. This is a proposal for the upcoming budget. And whatever was spent in the past, you can raise whatever issues you want to about it. But going forward, we got a budget to put together, and this is going to compete with all sorts of other proposed expenditures in the budget. So I don't think it's an unfair question to ask, with this large a proposed expenditure, what in this coming budget are you willing to not pay for in order to pay for this? If the proposal is in the general budget is we don't want to see any tax increases, we don't want to see any expenditure increases overall, but we're going to take $500 million of it out of the general fund now to pay for this, you're going to have to cut $500 million from somewhere else. Is it going to come out of long-term care? Is it going to come out of the K-12 education? Is it going to come out of special education? I mean, is it going to come out of, where's it going to come out of? I think it's a fair question to ask, rather than pretending this bill just exists in isolation. So I've got a problem with it in that regard. I don't see this as sustainable in the long term. I agree with everything Senator Wickland had to say about needing to address those long-term issues, and I'm not sure the federal government's going to be satisfied by saying, well, it's going to expire again 5 years, we'll have to have this discussion all over again. I think we're better off finding some sort of long-term funding mechanism. If this is going to be the long-term solution, let's find a long-term funding mechanism. If it's not, let's find some solutions now. Let's tackle this problem now and address the rising healthcare costs. Because it seems to me, even if this ends up having to be a patch, which I don't like the idea of, and I'd like to keep the pressure on to try to solve the long-term problems, it seems to me this actually takes the pressure off and supports increased costs in the healthcare industry, with the knowledge that government's going to come along and pay for reinsurance anyway, so we'll pass those costs along that way to the taxpayers instead of cutting our costs in the healthcare delivery system. So there, I'll get off my soapbox now, and thank you for the time.
Mr. Chair, I'd like to respond to that.
Senator Dahms.
Right now, we could take it out of $661 million excess we have.
Any further member discussion before we go to closing comments from the bill author? Senator Dahms, any closing comments?
Well, thank you, Mr. Chair, and thank you, members. I know we have a lot of discussion about this every time we do this, and I know that we have differences of opinion. And certainly, these discussions are good, because if we can stem anything out of these discussions to drive down the cost of healthcare, we certainly should be looking at that. But until we do that, we have a market that we have to protect, and that is the individual market. And there's a difference in opinion of how many members that provide services from this market. There's a difference of opinion of how many dollars it reduces the premium. But putting all that aside, right now, it's probably the only system we have that works in that marketplace. And so with that said, I would ask for your vote to pass this out, to move it to Health and Human Services.
Senator Dahms renews the motion that Senate File 333 be recommended to pass as amended and be re-referred to the Committee on Health and Human Services. All those in favor indicate by saying aye. Aye. Opposed, say no. No. The motion prevails. With no further business on today's agenda, the committee is adjourned. Thank you.